Welcome back to the channel. Today I have pediatric dentist Dr. Jarod Johnson, who is going to talk a little bit about pediatric dentistry and kind of dental specialties in general. Jarod, thanks so much for coming on the channel, and again, just great to have you here. What's the best part about being a specialist versus a general dentist?
Well, for me, when I went into dental school, it was, the first goal is to become a dentist. And when I went into residency program, my mentality was a little bit different. I was more focused on something I really enjoyed doing, and that was working with kids. And I put a lot more effort into my education because I felt like the education I was doing was really for me in my career. And I didn't feel like I had that impetus when I was in dental school. So that's one of the most exciting things is being an expert in the field. When you come out of dental school, you really don't know what you don't know. There is so much out there to learn in dentistry. And to think that you know it all when you graduate is just crazy. I'm 5 years out of my residency program, and I'm still learning and trying to get better at treating kids. This is a lifelong process, and there's many options for you. You don't have to specialize. There are great general dentists out there, but one of the things I like is being an expert in one specific area and being exemplary at it.
That's really interesting to kind of touch on what you said there, like the idea of kind of finding that field that you were like really passionate about, and that it's just like so much easier to pursue education in that direction. I can totally see how having like a focus like that would be more fulfilling than trying to be, this jack of all trades.
And if you're coming out of dental school right now and you're not sure what to do, one of the great ideas that you could do is do a GPR or a general practice residency, where you get a lot of more exposure to more difficult procedures in a hospital-based or university-based setting. Maybe you're doing some more sedations, you're doing more complex endo, more complex fixed prosthodontic work. And those things can really make you a better dentist. And if you're not sure if you want to specialize, that's 1 year where you just got a huge amount of experience up on your peers by going into one of those programs. So if you're not sure if that's something you want to do, that or the AEGD program, which is a little more cross-based or fixed work, those are great options if you're kind of on the edge, not sure, and you want to get more experience to some more complex things and still have an instructor to back you up.
I think that's really a great point, especially now, like with everything being so weird in dentistry, it's hard to find a good associateship with, there's so much uncertainty with COVID and the economy that I think that would probably be a great option for a lot of reasons to try a GPR, AGD, really get some exposure to new, just all these different ideas. I think in dental school, I think it was like 8 crowns or something. I mean, it was like not a lot. I did endo on 3 teeth, and you really realize, your first year out that you don't know much at all. I think that's a really good point. Now, do you think as a specialist, there's anything that you would have like frustrations with that a general dentist wouldn't?
Yeah, I think every specialty is gonna, you do it every day. You are very good at what you do, and sometimes, you got to know when something's too complex for you to handle. And with kids, maybe that's behavior. Maybe it's understanding the carries risk of that kid and knowing that if they have, a ton of work to do, a stainless steel crown might be a better option than the filling that's going to have to get redone in 2 years, and if the parents don't achieve the habit. But I think, it's kind of my job too to, take care of the kid, and, it is what it is. You can't get too upset about it. It might be frustrating at times. I had one case where a general dentist treated a tooth and then they referred him to me because it didn't go well. Well, they didn't get an x-ray on the tooth. They just put class 1 amalgam in the tooth.
Oh, wow.
And there's mesial decay. And it's like, now insurance isn't going to pay for that. You have to explain that to the parent, and you're kind of the bad guy. And, it's frustrating, but it's just part of the job, I think. And I'm sure endo has the same thing where a general dentist may have started something and it broke a file or something happened, a procedural error, and they have to clean that up too. And oral surgery too. They might be, have someone with a sinus exposure that was caused by extracting a tooth. And it's just the nature of the specialty. And I think a lot of people might get a little territorial about it, but it's
right. Yeah,
it's just part of life, and nothing I do is 100% except for extractions. So
it's true.
That's pretty tough, dude. And knowing what cases are too difficult is probably the best thing. And if you have a question, just reach out to your specialist and say, hey, I had one reach out to me, and I said, you can treat this kid. This is what I would do. And they ended up treating the kid. And I didn't see him, but it worked out, and it's a great relationship you can have with your specialist.
That's such a great point. And I actually thought about doing a video on that, just the relationship between GP and specialist, because the best relationships I have with specialists are one where we almost talk shop on a regular basis. Like every time I talk to my endodontist, I kind of sneak a question in there, like what's the best way to get a tooth out of pain, or what medicament do you guys use? Or if I talk to my ortho about a case, I'll ask some pretty detailed questions about not only the case specifically, but when do you prefer to treat class twos and things like that.
Another thing that might be good is when you refer a patient, especially to pediatrics, is don't come up with a treatment plan. Like when you come in and you've already put in mind that they need a filling and they really need a crown or sedation or something else, it kind of makes the specialist look a little more greedy when we're really trying to do the best thing for the child. When I refer to my orthodontist, I write for evaluation and treatment, and then if I see any areas I want to look at, I'll write that down on referral. But I don't say they have to start treatment. I don't say anything along those lines that I want to take out C and H right now. I just say ectopic canine, ectopic upper threes, and let them make the call. 90% of the time we agree, but it's just a way to, plan to see the parents just might be what happens, and they'll come up with a plan to best take care of you.
Yeah, that makes a lot of sense. So kind of back to dental school, did you know right away, like first year of dental school, freshman year, you wanted to go into pediatric dentistry?
It was one of the specialties that and endodontics I had an interest
Oh,
in.
okay, right, yeah.
But I wasn't sure I was going to probably specialize until we got into clinical rotation because I didn't know how, third year kids would go. And that's when I really realized that it was, it was really fun to be with kids. That every day, your day is different. They say some funny things. They're humorous. They're compassionate. They're friendly. You can really create a story with them. It's just an exciting part of the industry. And also to be able to take care of them. And, nothing I do, I'm not doing the high-end cosmetic cases. I'm not selling dentistry. This is all essential dentistry, essential healthcare. So that's something, I mean, you need it. This is what I recommend, and you don't have to worry about trying to sell a case to anyone.
Yeah, that makes a ton of sense. Once you made that decision in dental school to specialize, did you change any of the things that you were doing in dental school? Like, did you approach dental school differently? And sort of more specifically, like my friends that specialized that knew they wanted to do it, knew they wanted to go into orthodontics, it was like they were so involved with all the extracurricular stuff and fundraising things. And, obviously you have to keep your grades and board scores up, but is it really a lot more work trying to get into a specialty, or do you find that you would have put in kind of the same effort, either way?
I think first and second year, I probably would have put in more effort than I did. I was kind of a mix of an A, B, and C student, probably more on long, closer to a low B average. And then I realized that wasn't going to cut it when I wanted to go against my peers. So ended up third and fourth year, I was mainly an A student in clinical rotations. I really put a lot more effort to try to bring that average up because I knew I was weak there. If you can all join some organizations. If there's a specialty you really want to do, join, the pediatric club. If they don't have one at your school, maybe that's something that you get together with the faculty and try to start. There are also other extracurriculars, volunteering. If you've got an event at your school where you treat veterans, or if you guys do a free dental care day, a mission of mercy or something like that, all those things are going to look good. And if you have an interest in research, that can also help out as well, being a part of the research team.
Yeah, that makes sense. And so the next question I had for you was kind of already answered, but it was, would you do anything differently in dental school today? And I know you said, the sort of that first and second year might have put in a little more work. And for me, I would say the same thing. It was like I really am interested in orthodontics, and that might have been a fun way to approach it. But my first and second year, I was ranked like 70th in the class or something, and so that sort of made the decision for me at that point. Do you find like the personal connection thing, like when you said sort of pursue some research in that direction, or kind of I would think get to know people in different residencies. Does that make a difference in applying to a residency, or is it all just what you look like on paper with your activities and board scores and things like that?
Yeah, I think it definitely depends. So one of the things you may want to look at is where have graduates gone from your school to residencies
Makes sense.
that they've been impressed with. So at the University of Iowa, one of our faculty, Dr. Mike Nellis, so I sat down with him, and he had written letters of recommendation for almost all of the pediatric dentists that were coming out to apply for residency programs. And he knew exactly which schools had Iowa grads come to him, what their experience was like with the graduate. If they performed well, the residency program is likely going to want to have more graduates from there. I know at the University of Iowa, my mother was faculty there for a while, and I was actually at UNLV, but they had a lot of people in their periodontic residency that came from UNLV because they had a great surgical experience, and that reputation of UNLV's surgical experience carried into the applicant pool, and they really enjoyed having residents that had that experience when they're doing a lot of those periodontal surgeries. So finding out where you can go, and then I would not get discouraged if you're like me and like you and you weren't in the top half of your class, you can still specialize. Hitting back that GPR, the general practice residency, there are tons of them out there, and you can find one. If you want to do endo, find one that does a lot of endo and get in that conversation now in your third or fourth year. If you know you're not going to be, and have a backup plan. I actually was getting ready to apply for general practice residencies because I didn't match, and I got a post match spot. But I was getting ready to apply for that because I knew that would bolster my resume when I came back the next time. I'd have more experience with sedation, and that would be something that would be advantageous to the applicant when they look at it the second time. Not going to work, and nothing wrong with going to work for a little bit, but if I wouldn't be going to a public health center and treating kids there, that's something that could look good as well for pediatrics. But really having that extra experience can really show you're committed and elevate you to another level if your grades aren't where they want to be.
Oh, that's really interesting. Were all of your co-residents straight out of dental school, or did you have anybody that was doing a career change, like general dentist for 5 years and then came back for pediatrics?
Yeah, we had some that had come back for PO. Very, very good clinicians, and they were actually in a public health area when they came back, and they saw a lot of kids in their job, and they were passionate about it. They served underserved kids, and I think that really helped coming back. Being away from school for a while to have a nice resume and application, and I mean that's what they look for with applicants, especially if you're coming back. Public health service might. I mean, most pediatric dentists see Medicaid, so if you don't have that in you, that it's not as easy to go into a program and be compassionate about caring for everyone.
Yeah, no, that's excellent. What do you think of this idea that, the specialties are kind of going to be less important in the future, that general dentists are going to be kind of, the super GP and take over everything?
I think it just kind of depends on the way that I guess dentistry goes. I mean, do we turn into it where it's like a Walgreens or a CVS where it's all corporate owned? I mean, if that's the case, I think there's going to be probably definitely more competition to keep it in house unless the organizations are farming out things to the specialists and hiring the specialists to kind of have like I guess a big group practice where you have every specialty under the bus, and then you have the GPs there to do the restorative, and that could be a way it goes. I would just say do what you're comfortable with. If you like doing a procedure or you want to get better at it, take the CE and get better at it. Start with simple cases. If you want to enjoy those things, there's no reason you can't just be a general dentist and enjoy a wide variety of procedures. But you want to make sure you're practicing at the standard of care that you would be held to as a specialist.
Excellent. What do you think the most misunderstood aspect of pediatric dentistry is for like general dentists? What do most general dentists just not know about the specialty?
I think probably managing the restorative plan from the patient's caries risk is what I see. I mean,
Interesting.
it's I learned it the hard way too, because you see, oh, it's a class two. I can put a class two in there, and that will treat the problem. But if the patient's a high risk patient and they're three, the probability of that class two lasting on a molar that needs to last till 12 is actually probably pretty low.
Got it.
So, on these younger kids, I'm advocating for a lot more full coverage restoration, whether it be a zirconia crown or a stainless steel crown, just because that tooth needs to last. And I don't want to have to, the biggest thing I hate doing is doing my work over. I just finished an OR today, and we take tons of kids there. I usually do 6 kids a day. We go 3 days a
Wow.
month. And over the last 5 years, I've only had to take 4 kids back. And that's because, I treat them a little more aggressively based on their caries risk. I don't want to put a kid to sleep twice. Obviously, there's risk of sedation and things. Um, but I think trying to find out what's the balance going to be of the patient's caries risk and a long-term plan for their restorative plan. And I give both options to parents. But sometimes those younger kids are better off being a little more aggressive. I think I was at the Chicago midwinter talking to a dentist, and I showed him a class 1 occlusal on a 2-year-old. And I told him, I'm going to treat this with full coverage. And he said, you're crazy. That's too aggressive. And I was actually going to do a ball crown because the kid wouldn't sit for numbing and drilling. And that's not aggressive. I'm not prepping the tooth. In this case, I'm just sealing everything up so it doesn't get bigger. It's actually more conservative. But sometimes there's just a disconnect, and stainless steel crowns, probably, full coverage of zirconia, probably get it better at. But I think if you explain to the parent the right way and, give them the options. We've had some that come back, and when the filling breaks, I say, well, what would you like to do? We can replace the filling, or we can do the crown. And 100% of the time, they say, oh, yeah, I remember that conversation. Let's just take care of it with the crown.
Yeah, that makes sense. You mentioned hall crowns, and that's pretty cool. I've been following that pretty closely, and I know you're one of the big voices on Dental Town, especially for hall crowns. Is that something that's being taught yet in residencies or even dental school? And then for those that don't know, what is a hall crown? What's the difference between a hall crown and doing a regular stainless steel crown?
So a hall crown is essentially an indirect pulp cap where you don't actually prepare the tooth, and it works really well in kids because you don't have to numb or drill on the tooth, and there's no local anesthesia involved. So what happens is, the way I explain to parents is actually I'd say, well, your kid's probably not going to cooperate. They only have so many needs. It's not worth putting them to sleep, taking the risk for that. We can maybe do SDF and delay this and see them more frequently until we can get their behavior up to speed to do a conventional restoration. Or we can place a crown without having to drill on the tooth. And what that will do is it'll seal the whole cavity in. You won't get sugar anymore. And as long as the cavity's not into the nerve, which in this case, I don't think it is based on your x-ray, I'll show them where the nerve and that we have adequate tooth structure remains. This will solve the problem. And we can do it today. Would you like to do that? And most of the parents say yes. There's some that want to wait and try to delay and try to do a white filling later in time. But it's kind of funny. It's very well done over on the other side of the pond in the United Kingdom. And it's changed. I wouldn't practice without it, to be honest. We can do them the same day. That can free up chair time for another kid. It'll solve the problem. There's not going to be a difference in outcome in these smaller, to moderate sized class 2s. Obviously, if the tooth needs a nerve treatment or a pulpotomy or an extraction, it's not going to work.
Sure.
But that comes with your treatment planning. And I'm passionate about it because it works and people think it's crazy. But I've been doing it for almost 4 years now and very, very successful. And it's super easy to do. I honestly wish I could go out and teach public health people how to do this because I would get less referrals for small lesions that could be managed with it when they could just take care of that and not have the patient have to drive an hour and a half, 2 hours. They could take care of it at their office, and that would free up my chair time and better serve their patient populations too. So I think from a public health standpoint, it totally makes a lot of sense in underserved kids who don't have access to care. And whether you agree or disagree with it, you don't have to do it. I don't do a lot of other things that some other dentists might do, but it definitely works. It's definitely another tool in your toolbox, and you got to take it for what it's worth.
Yeah, it's so wild. It's just it's so anti everything I was taught in dental school. I came out in 2011, so even up to 2011, we had instructors that would say you have to take every last ounce of decay out, even if you hit the pulp, you cannot leave any decay in the tooth. And more recently, the research is really clear that that's not the case. That we should leave, a little decay. It's better to leave a little decay on top of the pulp and seal it up with the resin. And so that's interesting. But even to go further with a crown and just, no prep, no anything else, to just put a crown on the tooth, and the research says that it will last. It'll arrest that decay. That's really, like you said, I think that would be such a great service. I worked in public health for a year after dental school, and there were a lot of kids that I think we could have saved a lot of headache with that. I had kids that, they're screaming in the chair, and mom and dad don't really have many other options other than the public health clinic. And so that would be probably a really good, tool to have in the toolbox.
Yeah, and especially on these young kids, when we look at getting them in early, if you catch something that's really small at a young age and you can do this on the kid, like that's so much better than having them come down the road and come in at 3 or 4, and then they've got a mouthful of decay, and now we've got to put the kid to sleep. Like it's pretty simple. We like to get kids in early, and often this is a great tool for primary teeth. And it's kind of interesting because when COVID hit, we had a lot of patients that had moderate size class twos that would have been candidates for it and get shut down. And they're coming back now and they need pulpotomies and extractions, and it's like maybe I should have done that more often for them versus
Interesting.
kind of on a schedule. So.
Wow, interesting. What do you think of silver fluoride? I know that's another controversial topic.
Yeah, I think it works. I think you got to use the right case selection. It's not obviously you can't put. There's no amount of fluoride you can put on someone's teeth to make them stop drinking, Mountain Dew or having crackers all the time. Like if they don't change their habits at home, it's not going to work. The research shows it mainly works better on smooth surface lesions rather than interproximal decay and occlusal decay, and that's just because kids are eating junk. So
okay.
if it's a posterior tooth and it's a candidate for a Hall crown, I'm more likely to recommend that than SDF. But one of the things that I like about SDF is you can, on permanent teeth, you can use that definitely. If you've got a hypoplastic molar and you know those are going to be hard to numb, you can apply that 2 times 2 weeks apart before you start treatment to definitely help out with anesthesia and not have to have that visit where you have total lip anesthesia and you can't get them numb. And then also for indirect pulp therapy, it can be used as a desensitizing agent if you've got adequate remaining dentin thickness. And with one of the new products, I use both Evangelist and Revastar, but with Revastar on permanent teeth, if you're using that for an indirect pulp cap, you can actually have a more aesthetic outcome. It'll lessen the staining of the SDF, and you'll also still get some fluoride uptake, so it'll still get some silver uptake, and have a more aesthetic outcome. So I've been doing that a little bit more on posterior teeth where we're actually doing what you're saying, leading decay. And we've had great aesthetic outcomes with that.
Oh, that's great. That's good to know. I was excited about SDF before it was like right before it was allowed in the United States, and it was that 2014, something like that we could finally use it in the US. And I remember like as soon as it came out, within the month I bought some because I was just so intrigued by this idea. And I've had some really good results in some cases. One thing that I've used it for, and I'll take some pictures and show you some of these recalls, but you get that like cavitated, number 2 or 15 on the buckle where it's really deep and it's going to be incredibly challenging to fill because you're drilling out the buckle and trying to pack a cord. I've done it before where I'll bring them back like 3 appointments 2 weeks apart where I'm putting SDF on that lesion and they're pretty deep. And if I can get it to be rock solid, the last time they come in, I'll just fill it with glass ionomer. And it looks awful because it's, this black SDF and it's filled with, it looks like an interim restoration. But I have some of these that are like 3 years out and there's no sign of any recurrent decay, anything like that. And I had some mixed results with primary teeth on it. I think I can think of 2 occasions where there was some pretty deep decay that we tried to just buy a little bit of time with SDF on. And then within a few weeks, the tooth abscessed and I had to take it out. Could that be related to the SDF treatment, or was that just sort of going to happen because the decay was that deep?
Yeah, so if you look at radiographs and how long it takes for like rarefying osteitis or radiolucency to show up, it's actually 4 to 6 weeks before that even shows up in your x-ray. So that's why our indirect pulp therapy is never going to be 100% successful because we're not getting in that window. So I often will use SDF as a diagnostic aid. We'll put, if we're doing like a primary tooth, we'll do the Evangelist. I'll put it on twice 2 weeks apart. And then I'm putting a glass ionomer over that, just like you did. And that's to prevent food impaction and to give us a little more longevity because that will seal it as well. And then we'll put the kid on a 3-month recall plan where we can reevaluate that and get to the point where we can treat that. So like you're doing with applying it 3 times and putting glass ionomer in, that's kind of similar to what I'm doing with it. And I find that to be very successful. If we have kids that we're not sure, mom comes in and they don't know when the tooth hurts, and I'm not sure because the kid won't tell me, we'll often do this where we do the SDF twice, put a glass ionomer in, have them back in 3 months, get a new x-ray and see if we have a problem or if we can move forward without doing pulpal therapy at all. So kind of similar to what you said is definitely how I use it. It's not going to be something that fixes everything, but it definitely, it's, like a Hall crown, another great tool to use.
Right.
I use it a lot on primary molars and also permanent molars with deep decay to try to get the kid, a 6-year-old, they may not be able to sit to get the work done, and that can buy us some time where we can see the kid every 3 months, get them comfortable with seeing me, and then finally get to the point where I can do treatment on them in office.
I checked out your Instagram, and it looks like you guys have a ton of fun on there. Like you've got the Jeep, the little Power Wheels Jeep that you have is really cool. So you have the kids. Are they driving themselves back to their appointment?
So I bought that for the hospital. We actually have one of the biggest problems is separation anxiety from the parents at the hospital. So from when the parent gives their kid over to the nurse to get them back to the room for the anesthesiologist to go ahead and get them comfortable. I can tell you, we just used it today. The kids just love driving it down the hall. They don't have to have preoperative midazolam. They don't have to have, the screaming and crying. They get excited about it. It just makes it's about patient experience and and the comfort you want for your patients and parents. And, when a parent sees that and their kid's driving back, when it could have been them getting held and they're screaming going back, they know they're in the right place and in good hands with all the nurses and people providing care for them while they're asleep.
Yeah, no, that makes such a difference. My son, when he was 1 year old, he's 8 now. When he was 1, he had an operation. It was done at the University of Michigan, and they're like that too. They're just, everything is just, next level. They're really attentive, and we were really worried about it, and they had him in this, it was going to be where he was for the operation, but it was toys everywhere, and he was playing with them. And then when they wheeled him away, he's still playing. So as a parent, it was really nice to see. So, even beyond the kids, I bet the parents, it probably makes their experience better watching their kid, drive the little Jeep back. And how many days a week do you do operating room?
I'll do 3 days a month. So
Okay.
prior we were booked out a while. Now we've had a little bit of challenge getting back, but we're slowly picking up, getting patients back in the door, and we filled next month already. So a lot of kids that unfortunately have had more extensive needs now, and I think cooperation's been a little more difficult for some kids during this time too. I think everyone's under a lot of stress, so it's just nice to be able to have that relationship with the hospital and that facility to offer care for kids that need it.
So what's the biggest secret that general dentists don't know about treating kids?
Well, that's a great question, and I actually didn't know the secret when I graduated residency either. But the biggest secret is you have all these parents that come in and they can't figure out why their kids are getting cavities. And the biggest thing that we aren't taught in dental school is about diet and kids. We know these parents that they're well-off families, they're brushing twice a day, but they're letting their kids eat things that they don't think cause cavities. So Dr. Roger Lucas has a snack guide. He's the dentist dad. He's got a book, I think, More Chocolate, Fewer Cavities. Read that book or listen to his podcast with Howard Fran on Dental Town. It's a game changer. I didn't realize it. We actually have a poster here in my office on sticky snacks. So a lot of parents don't realize that crackers, chips, dried flours, and starches are actually I think it's 7 times more stickier than bread.
Oh, interesting.
Starch breaks down to sugar in your mouth. And if it's sticking between your teeth all day, you're going to get a cavity. And we know that those are the go-to snacks for kids. So a lot of parents, they come to us and they have all this work to do. And they're like, well, I'm not giving them candy. I'm not giving them juice. And they know that, but they don't know these other things. So the biggest secret for me is actually to invest in Dr. Roger Lucas's hygiene program and include this as a conversation at each visit. Each new patient gets his 2-snack guide with our logo on it as a magnet for their fridge, and also his handout of over 50 snack ideas that won't cause cavities. And that's probably the biggest thing that I see, because when you can have that conversation, you're going to have some people, they may not want to make the change. A lot of these families are going to realize that is and look for alternatives. And if you're telling them not to eat it, you want to give them a list of things that they can eat. You don't just say don't eat crackers and chips, don't eat the sweets. But if you hand them a list of things that are good for their teeth too, they're going to be more likely to make that change. So that's probably my biggest secret. Is the biggest part of our hygiene program is actually working on their diet, because everyone knows they're supposed to brush twice a day.
No, that's great. Do you ever get anybody on a high fluoride toothpaste like Prevident or something like that, or is that something you save for kind of teenagers on up, or do you get younger kids that you prescribe?
The main benefit to fluoride right now we know is the topical benefit. So if I've got children that are high risk, that are under 6, we're going to put them on a 3-month recall program. And the main reason for this is for me to, check on their teeth. If there's something small, I can do SDF, I can do a Hull crown, or we can do interim therapeutic restoration. And they're going to get a fluoride treatment, and that fluoride is going to help reduce their caries. I think it's like a 43% reduction in decay.
Wow.
And also those 3-month recalls, if they're high risk, it's going to get them more comfortable coming. Once they're 6, they can have prescription toothpaste prescribed to them. We worry about fluorosis using a high prescription toothpaste in kids that are under 6, because that's when the crowns of the adult teeth are developing. So, and also when you have them coming every 3 months, you can, if they're having juice, you can get them to stop that. If they're not brushing twice a day, you can get them to start, work up sequentially with motivational interviewing to, I remember going to the dentist and they're like, you got to stop doing this, and this. Well, if you tell someone they're doing 4 things wrong and you don't have them focus on one, you're never going to make any progress. I have hypertension, and my doctor said, these are the things you can cut out. I cut out one, we checked it, and he said, wow, it's nice to have people actually listen. If you would have told me I need to do all 4 of those things, I probably would have said, well, I can't do that. That's not realistic. So being realistic with your patients and motivational interviewing, if they don't want to change it, they're probably not going to change it. So find something that they want to change. And when they come the next time and they see an improvement, maybe they'll be ready to change the next thing that you recommend.
Yeah, that's so great. That's something I never even thought about it till you said it there, but that's something I kind of always try to do intuitively with my patients, especially teenagers. And again, I never, articulated it the way you just did there, but that's 100% true, because I've got people that say, I drink energy drinks, and I'll tell them, well, I know it's I can't tell you not to drink energy drinks. You're not going to listen to me. But if you're drinking 3 a day, see if you can do it, 2 a day, or even after you drink the energy drink, kind of swish around with some water and try to wash it out of there a little bit. Little things like that might make a difference. About half the time, they actually, will change their behavior. And I feel like teenagers are sometimes the hardest people to motivate.
Yeah, definitely. I think I was one of those too.
Yeah, 100%. Yeah, I went to the pediatric dentist. I I think that at one point I drove myself to my pediatric dentist, and I think that was the time that my parents decided it was time for me to go see, their dentist. So if anyone's interested, they can find you on Instagram, and it's at Arctic Dental. Is that your Instagram handle? At Arctic.
It's ARCTIC Dental. Some people forget the first C.
Okay, nice. And then you also host a podcast. Can you tell me a little bit about that?
Yes, I'm the host of the Sprig podcast, and we're just focused mainly on everything pediatric dentistry from a business standpoint to an education standpoint. We just did a huge series, just kick it off on COVID and your practice and options. And we're really trying to be, as well-rounded as we can be with a focus on pediatric dentistry. That's not saying it's only for pediatric dentists. General dentists would enjoy the show. We're talking about new technologies such as zirconia, all white crowns for kids. We've got some great topics coming up on marketing for your office and just, soup to nuts, so everything dentistry. I love dentistry. I love being a part, talking to people. I learn something every time I do something new, something I need to implement in my office. We've got, I think, we're coming up on almost 20 episodes released. So if you want to go back, let's do a few episodes. We had one we just recently did on health and wellness for the dentist and the dental team. That might be something that's interesting. And Kathy Jameson's been on from Jameson Management, and she's awesome. She has a wealth of knowledge on how to manage your staff, create a team environment. I just learned so much. I'm having so much fun doing it. So if you got time, you're exercising, cooking, go ahead, download it, and give it a try.
Awesome. Thank you so much for coming on today. That really means a lot. This channel's been a ton of fun, just kind of connecting with a bunch of different YouTubers and people active on social media. Checked out again some of the stuff you're doing on Instagram. Just looks like you're having a ton of fun. And again, just thank you for coming on, and look forward to talking again soon.
Yeah, thanks, Evan. I'd love to come back and talk about emergency treatment for kids and permanent teeth that they can't get into the endodontics that day or something like that. So.
Awesome. Thanks so much.
Yep. Have a great night.
You too.